Welcome, dear audience, to another educational session. Today, our topic of discussion is about syphilis and its complications in human eyes. Over the last decade, the cases, the numbers of primary and secondary syphilis has increased a lot. And as a consequence of this increase in manifolds of the syphilis, the eye complications have also increased. It is very important to diagnose syphilis in time to prevent irreversible damage to human vision. In order to discuss this very important and challenging topic, we have requested and invited a consultant, a physician, a scholar, Dr. Eleftherios Georgianis, who is an expert in this field. He is a consultant ophthalmologist at Manchester Royal Eye Hospital with special interest in uveitis and medical fatigue. He graduated from Greece Thessaly Medical School, and later on he did PhD in transplantational immunology from the University of Oxford. He completed his ophthalmology specialist training in Liverpool with fellowship in medical and retina uveitis from Moorfield Eye Hospital. He is the lead of adult uveitis research at Manchester Royal Eye Hospital and has interest in biomarkers of immunosuppression and immune profiling of patients with non-infectious uveitis. He is actively involved in research and publications. He is an associate editor of BMJ Open Ophthalmology and a review editor of Frontiers in Ophthalmology. We are very thankful to Dr. Agorgianis that he has accepted our invitation to educate our audience about this very tricky disease and its manifestations in eye, to educate our audience, to guide them so they can better be prepared to teach and manage their patients. So without further delay, I will welcome him. Please, Dr. Agorgianis.
Thank you very much, Dr. Mirza, for this kind invitation. It's a great pleasure to spend this morning to discuss ocular syphilis with you. Thank you. So, syphilis remains a major public health concern worldwide, with WHO estimating that in 2022 alone, over 8 million adults acquired the disease. Patients with ocular syphilis comprise about 1 to 2.5% of all uveitis cases in tertiary centers. And traditional syphilitic uveitis has been considered to lack any specific clinical or imaging features that could point to the exact underlying etiology. Today, I will discuss a number of ocular phenotypes which present with specific features which should allow the ophthalmologist to suspect the correct diagnosis. Serological testing allows a presumptive diagnosis of syphilis. Broadly, serological tests for syphilis can be divided into treponemal tests, which are specific for the infection, and they would be expected to remain positive following treatment, and non-treponemal tests, which, although non-specific, they can serve as reliable markers of disease severity. Nowadays, testing starts with a treponemal test, and if this is negative, then the diagnosis of syphilis is unlikely and no further testing should follow. If treponemal testing is positive, then non-treponemal testing like VDRL or RPR should follow. If non-treponemal testing is positive, then the patient has either untreated syphilis or treated syphilis, whereas in cases of a negative RPR or VDRL, then the patient has either treated syphilis or the result reflects a false negative in the context of early or latent untreated syphilis, or in cases where there is high concentration of antibodies in the serum, and this is the so-called Prozone phenomenon. These are the SUN working group criteria, which were proposed in order to carefully identify syphilitic uveitis cases for research purposes. These are not diagnostic criteria. As you can see in the table, a number of ocular phenotypes have been considered, and this reflects the multitude of compatible clinical presentations. And this, as discussed in the previous slide, serological testing remains essential for carefully defining these cases. A degree of anterior chamber inflammation accompanies most presentations of syphilitic uveitis. In the literature, syphilitic iritis has been described as either granulomatous or non-granulomatous. And in this series of 250 eyes from the 1930s, over 1/3 of cases lacked any associated findings, for example, posterior segment involvement. However, in cases of isolated anterior chamber inflammation, particularly in the absence of the typical iris pathology, which is extremely rare, it would be virtually impossible to distinguish these cases from non-syphilitic uveitis. I will now discuss a number of ocular phenotypes which are affecting the posterior segment of the eye, and they present with fairly pathognomonic features for syphilis. Placoid disease is the most common presentation nowadays. This is an example of a 35-year-old male who is HIV negative and presented with a 3-week history of right painless visual loss. He reported the RAS 6 months before, and on presentation, his visual acuity was 20/50 in the right affected eye. There was mild only right vitritis. Pseudocolor imaging showed a posterior pole yellow placoid lesion with a demarcating line, and these changes were far more discernible on autofluorescence imaging. This is the typical appearance on structural OCT imaging, and these are the typical outer retinal changes with ellipsoid zone loss, thickening of the retinal pigment epithelium, alongside these nodular elevations. The patient tested positive for syphilis, and a diagnosis of acute syphilitic posterior placoid chorioretinitis was made. This variant of syphilis was originally described in the 1988 and took its current name in 1990. And images from these representative publications are shown in this slide. We have been observing an increasing incidence of placoid syphilis over the past 20 years, and significant geographical variation exists. Interestingly, in certain localities, like in Cape Town, South Africa, where ocular syphilis is extremely prevalent, no case of placoid syphilis has been observed yet. In Manchester, placoid syphilis accounts for the majority of ocular syphilis cases that we see. In this sample of 35 patients, the majority of them were male, and their average age was 45 years old. About a quarter were HIV positive, and the vast majority tested positive for syphilis. And there was a single exception of an HIV patient whose treponemal testing was positive and his RPR was negative. And patients presented with variable symptom duration ranging from a few days to 2 years. As expected, painless visual loss is the most frequent visual complaint, and at least in our population of patients, skin manifestations reflect the most predominant extraocular problem in syphilis. It is important to remember that fundoscopic findings may be rather subtle, so this is why it is essential to have access to multimodal imaging. And the invariable hyperautofluorescence and outer retinal changes on structural OCT images are fairly pathognomonic. I don't find angiography particularly useful in diagnosing this variant of syphilis. However, fundus fluoroscan angiography would show progressively increasing hyperfluorescence, and on ICG angiography, you would expect to see hypofluorescence, which corresponds to the lesions, and this becomes accentuated at later frames. With regard to lesion topography, most lesions affect the macula, and infrequently the central macula might be spared. And concurrently, there might be associated features such as retinitis. These lesions respond very well to treatment, and this patient improves significantly with systemic antibiotics. And my personal preference is to prescribe a 6-week course of oral steroids. However, treatment failures may occur, and this is particularly in cases with late presentation, like in this male who presented with gradual visual decline over 18 months. Retinitis is another important presentation of syphilis, even more so because differential diagnosis should include viral retinitis, which can progress very, very fast. This is the case of a 42-year-old male with diabetes mellitus type 2 who presented with a right painless nasal scotoma over 4 days. On examination, his visual acuity was 20/25, and there was mild only anterior chamber and vitreous inflammation. On examination, there was evidence of a large patch of semi-transparent retinitis with some associated vascular seeding, and there was an adjacent smaller patch of dense retinitis with some adjacent smaller round lesions. The patient was suspected initially to have viral retinitis, and this is why he underwent in the referring unit diagnostic anterior chamber paracentesis, and he was treated with both intravitreal and oral antivirals. Eventually, the AC tap was negative for the viruses, and the patient ended up having positive syphilis serology. An appropriate treatment for this penicillin allergic patient was started. 6 days after starting treatment, you can see here that the retinitis has regressed significantly, and you can see that there are these superficial retinal lesions which are far more conspicuous now. And after 7 weeks, there is complete resolution of the retinitis, which has been replaced by chorioretinal scarring. Now, these superficial retinal precipitates are fairly specific for ocular syphilis, and this is a phenotype that we always need to bear in mind. This is another example of a patient who presented with a combination of punctate inner retinitis, another term for the superficial retinal precipitates accompanying retinitis, alongside the placoid lesion. And the placoid lesion is more conspicuous on autofluorescence imaging. This is another patient with a similar presentation with a placoid lesion with a demarcating edge over here, and inferiorly a patch of punctate inner retinitis. And a last example with punctate inner retinitis only. Increasingly, we are observing a number of patients who present with newts-like lesions. And 2 examples are shown in this slide. And these are compared with an example of typical newts on the far right side of the slide. In my practice, I always test patients with newts for syphilis serology. Finally, I would like to refer to a combination of optic disc edema and chorioretinal lesions, which might really suggest the presence of ocular syphilis. This is an example of a 45-year-old male with a history of genital warts. The patient was HIV negative, and he presented with right central painful vision over 3 days. His visual acuity was 20/200, and there was mild iritis and vitritis accompanying his presentation. On examination and multimodal imaging, the patient had optic disc edema with a large placoid lesion of the posterior pole, and you can see the corresponding autofluorescence imaging. We need to ask all patients with uveitis as part of their systemic evaluation about skin manifestations, and this patient had the typical maculopapular rash of secondary syphilis. Syphilis serology was positive, and the patient received treatment with systemic antibiotics and a long course of oral steroids. This other patient presented with bilateral visual decline over a couple of weeks associated with headache. And because of the presence of optic disc edema bilaterally, the eye casualty doctors referred him for a lumbar puncture, which showed opening pressure of 26, which is raised, and a positive RPR in both the serum and the CSF. There were associated chorioretinal lesions, which were more visible on autofluorescence imaging, and fluoroscan angiography showed bilateral optic disc hyperfluorescence associated with posterior pole vascular wall staining and capillary leakage. And it is a bit unclear whether the optic disc edema in that case reflected the degree of intraocular inflammation, considering the angiographic appearance, or it was secondary to the raised intracranial pressure, given the lumbar puncture findings, or whether it represented actually primary optic nerve involvement. An MRI might be useful in these cases to help us reach the cause. Regardless, the patient received systemic antibiotics and a long course of oral steroids. To summarize, although all of us are requesting syphilis serology for any patient who presents with uveitis or optic neuropathy, there are certain presentations of ocular syphilis with very distinctive posterior segment involvement. Placoid syphilis and punctating retinitis are the best examples. And I can also think of a handful of patients who presented in my clinic with newt-like lesions associated with optic disc edema, which ended up having syphilis. HIV serology should be requested in any patient with suspected or confirmed syphilis. And in my practice, due to certain modes of transmission, I prefer to test these patients for hepatitis B and C as well. In cases of diagnostic uncertainty, especially with retinitis, proceeding with an anterior chamber paracentesis for viral analysis of viral PCR analysis is sensible. If you are dealing with a patient who has optic disc edema, especially with significant visual decline, then it's sensible to proceed with MRI brain in order to differentiate between papillitis and optic neuritis. And in my practice, for patients with isolated ocular involvement, in the absence of any neurological findings, I don't push for lumbar puncture, and I do prefer to defer this decision to my internal medicine colleagues. With regard to treatments, when the underlying etiology remains unclear, and if certainly you decide to proceed with a diagnostic AC tab, then at the same time it's justified to treat the patient with oral intravitreal antivirals. Certainly, local steroid injections should be avoided in these patients at the beginning, and any confirmed case of syphilis should be treated with systemic antibiotics under the care of a sexual health specialist. Every patient treated for ocular syphilis needs to receive 3 days of oral prednisolone. And in my practice, I prefer a longer treatment course for patients with placoid syphilis and concurrent optic neuropathy. And finally, we have shown that patients with syphilis who have received an appropriate antimicrobial course can have systemic steroids quite safely. Thank you very much for your attention.
Well, Dr. Egorgianis, it was a very interesting talk, and you have pointed out and explained the practical aspects, how these patients should be investigated and managed. And I hope it will be very beneficial to our audience. But one thing I want, you have experience, a lot of experience in this. I want to ask you, when managing immunocompetent and immunocompromised, particularly patients with HIV, you find syphilis in the eyes. How long you follow up those patients, and your about this duration of management?
So that's a very interesting question. Actually, UK guidelines suggest that for all stages of syphilis, HIV positive and HIV negative patients should not receive any different treatment. And once a clear etiological connection between the ocular phenotype of syphilis and the diagnosis systemically of syphilis has been made, and of course, when there is no concern that there is any overlapping infection, I do not treat HIV negative and positive patients any differently. However, I may avoid the prolonged use of systemic steroids if the patient is severely immunocompromised. And I would like to involve the sexual health specialist quite early, because systemic steroids might actually interact with some of the antiretroviral treatment that the patients are receiving.
Right. Usually we go for PCR tests in these cases, but if the results are pending and we are waiting, clinically, how will you differentiate, Prof, about this acute retinal necrosis from syphilitic this retinitis clinically?
Clinically, the distinction might be quite challenging at the beginning. We would certainly test any patient for syphilis, and certainly if there is any doubt, I totally agree that it is very justifiable to proceed with diagnostic anterior chamber paracentesis. There might be some telltale clinical signs. For example, the presence of a placoid lesion might suggest the presence of syphilis. If the patient has punctated retinitis, these superficial retinal precipitates are highly specific for syphilis, and this might allow us to have a bit more confidence about the suspicion of ocular syphilis. But certainly, I totally agree. If there is doubt, proceed with the diagnostic AC tab and do proceed with interim treatment with antivirals.
Right, right. Well, Dr. Agorgianis, of course, this is an infectious disease and we use antibiotics to control it. And you have discussed about steroids use. What is in your clinical practice and your practical experience, which you feel that this is the threshold to introduce steroids in the management? At what point
So
introduce it based on your clinical judgment and experience?
every patient in the UK, and I believe the CDC guidelines are no different compared to that, would receive a 3-day course of oral steroids, prednisolone 40 to 60 milligrams daily, starting 1 day before starting antibiotic treatment. In my practice for cases of optic neuropathy, placoid retinitis, etc., I prefer a longer course of steroids. And typically I would offer this patient a tapering course over 8 weeks.
Right. Dr. Gorganis, if there is ocular syphilis, of course, and the CSF is negative VDRL, but CSF proteins and pleocytosis is there. Of course, you are in a tertiary hospital, all subspecialties are along with you. Do you go for the neurosyphilis or standard syphilis protocols?
Again, both UK and US CDC guidelines suggest for any patient with syphilitic uveitis, a neurosyphilis treatment protocol should be followed. So I just defer this decision to them, but invariably the patients will receive a neurosyphilis treatment protocol. And the preferred one in the UK is 14 days of procaine penicillin with probenecid.
Right. Well, Dr. Agorgianis, I believe this our educational session will be very beneficial for our audience, and they will learn a lot from you because you have got great experience in this, and it will help them in their management. I want to thank you on the behalf of our audience, and that you accepted our invitation to educate them, and we are looking forward to more educational sessions. Once again, thank you, Dr. Agorgianis.
Thank you very much, Dr. Mirza. It was a pleasure.